Welcome to the first episode of the Perinatal Mental Health Somatic Healing and Embodiment Series. This is our first topic titled Reading the Signs. Hey, Dr. Saida. We want to just share a little bit about why we chose this topic, what some of our experiences have been, and why we think it's so important to have this conversation. So I wonder, Dr. Saida, if you can share a little bit about what we discussed, why we wanted to make this where we start in this big topic.
Yeah. So we were thinking about if we have 4 episodes to say everything we want to say to people in the birth field about supporting people, what we want to talk about. And really important is in that first time you meet with a client to assess, to understand, to gather what do they really need? Like, how could you really best support them? What's their background? And for us as psychologists, as therapists, screening and assessment are like, skills that we have. And as a psychologist and doula as well, I have the skills from my psychology side, but not something that I learned in like my birth work training. And so I'm always thinking, okay, how can I like share the things that actually I find really useful as a doula, but the skills that I learned in a different field with, my peers. So this is an opportunity to do that. And I think anytime you're thinking about a life scenario where people are going to have a lot of changes, they're going to not just be pregnant, but then the hormonal changes that are going to occur, the body changes that are going to occur, family, relationship shifts, the actual labor and delivery process, which can be anything from a convenient couple hours, which is actually pretty intense because I had prodromal labor myself. And then also like multi-day sagas of childbirth, and then the postpartum period. So what can I know about you to help me help you through whatever could come up? And screening and assessment are a big part of that for me.
I think scope really plays a role in this too, because I think though we have the skills as a therapist and we're trained how to assess, birth workers, it's not really in their scope to be thinking about mental health at the forefront, but very much so doulas and birth workers and care professionals of all kinds show up to provide emotional support to the people that they're working with. And so I know in my experience, I used to be a hospital social worker and would get referrals anytime that someone screened positive on one of the patient health questionnaires. And it would be up to me to kind of assess, what was coming up for them and how to find the right supports. And I remember thinking, I wish that we could have supported them a long time before
Right.
now. I wish that all of the providers that they had touched point
Had thought about any of
had
this
thought about
before.
any
Yeah.
of this before. And the more I really started to talk to the other people that I worked with at the hospital, the nurses, the physicians, folks, just people in general didn't feel comfortable talking about mental health in general.
Yeah.
And I think that's also a reflection of our culture. I
Yeah.
think we don't even feel comfortable often or even know sometimes what's going on with us. And so screening tools can be a really good tool to help start the conversation. There are multiple out there that are validated for use during pregnancy and postpartum to at least help you start the conversation and give a little bit of a blueprint for how to do this, what questions to ask, what kind of areas to explore with people, and how to then get them connected with the right kinds of support so that they can feel really grounded and connected to that journey and all the ups and downs
Mhm.
and twists and turns that it's inevitably going to bring.
Yeah, absolutely.
So I want to just kind of start with some of those screening tools
Okay.
that we've been mentioning and just let people know that there are options out there. And though for many care professionals, in my experience, we don't really get trained in perinatal mental health in general, and knowing that there's a little bit of a different feel for mental health during pregnancy and postpartum because there is so much coming at folks. There's a lot of new experiences. There's a lot of just adjustments that people have to navigate and manage. There are sometimes particular kinds of questions that you want to ask to get at particular experiences that people might be having. And so there are a couple of screening tools that are more commonly utilized. There's a patient health questionnaire, which comes in the 2-question that sometimes people will use depending on the setting. There's the longer version, which is 9 questions and is really modeled after the symptoms that are listed in the diagnostic manual that you and I would use as clinicians. But it could be utilized by anybody. And though the goal with those screening tools is never to be able to diagnose after, it's really to just be able to ask the right kinds of questions for someone who might be experiencing some symptoms of depression. And so the PHQ is one that is commonly utilized. There's the Generalized Anxiety Disorder Scale, which again is modeled after questions in the diagnostic manual for anxiety. But again, in the perinatal period, we know that postpartum depression can sometimes look a little different than that classic
Yeah.
depression that people kind of think about and characterize. And a lot of times, even movies will
Yeah.
depict depression in a particular way. It can often have a lot of anxious features. So
Yeah.
what I often recommend is that folks use those two in tandem if they can, so that they can capture the full range.
Yeah.
And so, yeah, I mean, for screening, there's those two, and we'll kind of touch on a few in a moment. But I wonder for you if you can maybe think about and talk about for a moment in your experience, and especially navigating those two different worlds where screening tools can be useful. How do those really weave into, and why is it important for us to be, incorporating screening tools in our work?
Well, I think, one of the things that so you and I have like a different approach in the screening tools that we prefer because of the way we've used them, right? So when you're thinking about like mental health professionals who are coming into working with the perinatal population, they typically haven't been working in that specialization. Using the GAD and the PHQ-9 is more strategic because you get a whole picture. But when I'm thinking of like doulas in a quick moment of you're trying to gather a lot of basic information, I often think of the Edinburgh more because that one sort of has a bit of depression, a bit of anxiety screening, but it's in one, it's a little quicker, and it could give you at least the kind of information you need to know, like what's the next step. But you'll see in the field, and this is why we're talking about it, like people use different things. Some people are using a PSQ-9 across a lot of different perinatal spaces, and other people are using the Edinburgh. And so wherever you are, know that this is some way to think of it, right? That if you are using just the GAD or just the PHQ-9, you're going to miss something. You really need to use both of them. Where if you use the Edinburgh, you get two, but you're not getting as expansive of a picture. And that can be really helpful if you need a little bit more information. But I do think that with the doulas in particular, who I think of often, as like they're really spending a lot of time with families, you're going to pick up potentially on a lot of mental health things that are going on with the client, but also with their partner, potentially with family members that are around them. You want to have something in your belt to be able to figure out, like, what am I working with? Because wherever you came from, you might be a doula who, used to work in HR and you just have this calling for the work.
Right.
And this part is not your jam as far as like assessment and understanding mental health stuff. But you do understand that there's something funny going on in this house. There's something weird going on with this relationship, or this person seems a little off, but I don't know exactly what it is. A screening tool is perfect for that because then it gives you a little bit of a hint. This is a moderate issue. This is a mild issue. No, you need to refer them today. And in what level. And so the thing that I like about the screening tools is that when you look at the score sheet, it gives you information as the provider, like, okay, what am I dealing with? Even if you have no background. So you don't need to feel like you need to be an expert to assess somebody's mental health, even though you're being asked sort of to understand somebody's emotional well-being, which includes their mental health. So I just love, the usefulness of the tool. The other thing that I always want people to realize is that you don't have to be even a provider of care to give a tool. So I have given the Edinburgh to clients as a part of their intake paperwork. Like you can just check on this once a month for yourself, right? Like I might check in with you at the beginning and sometime in the middle and maybe at the end if I feel like there's something I want to reassess. But you can just sort of like know your baseline for yourself. And I think that that's very empowering for people to know the screening tools are self tools. You don't have to have somebody else administering the tools as well, which then maybe if you're not a trained assessor, it makes you feel more comfortable because maybe it feels weird to like give somebody a screening and you're like, I'm not that kind of professional, but they could have given it to themselves. So even better to have you in the room, to be hearing their responses, to kind of work through the questions. And, as we'll talk about in the next episode, you can make it unique and tailor to the client and tailor to yourself in the way that you need to.
Yes, so much of what you said is so important to remember. And I always emphasize with folks that the screening tool is a conversation starter, and
Yeah.
you're normalizing just talking about mental health,
Yeah.
and you're normalizing the opportunity, you're opening doors, you're planting seeds and watering and fertilizing
Yeah.
them so that folks can just feel open to talk about it. It doesn't mean that you're looking for someone who might have a diagnosis, or
Right.
you're, looking to hospitalize it. Like, that is not what this is for.
Yeah.
We're really just opening a door for people to talk about how they're coping and
Yeah.
how they're doing.
Yeah.
And for people who are not mental health professionals, this is a tool. That's
Yeah.
exactly what it is. It's a tool.
Yeah.
You said something that I want to come back to, in terms of, doulas. They have such an intimate relationship with their clients and the people that they work with. And oftentimes they see a lot of dynamics that are playing out in the family unit, in the household, within the person. People don't come to this work as a blank slate.
No.
They come with a whole lifetime of
Yeah.
experiences, and all of those experiences color and shape how they interact with us, how they navigate their pregnancy and birth journey. And sometimes part of their journey and part of their story is trauma. And
Yeah.
so I know that you have a lot to offer and a lot to say about that. So I wonder if you can maybe share some of your thoughts about some screening tools that are available to explore that, and how you might recommend we incorporate that as well, that component.
Yeah. I mean, when you're thinking about mental wellness, like how a person manages emotionally, a lot of it is impacted by what has happened to them in the past, and how do they cope with stress, with trauma, with, intense emotional situations. So you also want to gather that when you're also doing screening, which is not in the three that we named earlier, right? And so one area that I think is kind of helpful, because it gives you like a bigger picture, especially when you're thinking of a person birthing, especially if you're in some sort of support system, not just the medical provider that's going to see them for a few minutes every couple months and have more of a transactional relationship. Show me your body. I'm going to assess that it's healthy, and then ask me your questions and then go back out. But you're not integrated into their everyday life. You're not helping them strategize how they're coping through each stage, if that's not the approach of the provider. Certainly when we're working with the midwives, that's their approach. And this is really relevant to them as well. But for all the providers, thinking about like the ACEs, like the adverse childhood experiences that people could have had, it is a screening tool that kind of gives you a wider sense of a person, and it tells you a little bit about their family dynamic, which often then can get triggered or be relevant related to people's birthing experiences. So just a couple of the domains I wanted to share about the ACEs screening. It's looking at physical abuse. It's looking at sexual abuse, emotional abuse, deprivation and neglect with food and medical care, living with people who have really problematic personalities or behaviors like substance abuse, having someone who's been incarcerated as a parent, dealing with suicidality and depression and mental illness with family or people who are caring for you, having a transient experience, parents being separated, parents getting divorced, and also witnessing other people be abused, right? So you have a scope where you can ask a person questions that has been, validated to be helpful to understand the impact on people's mental and physical well-being for the future. But you don't need to get into all again, it's not like a diagnostic tool. It's like, oh, that's helpful to know that you had a situation where your parents were separated or something happened really traumatic, because it might inform stuff that's going on right now. You might find out that somebody was incarcerated or away from the family in their really important years earlier, and now they're here again. But maybe that gives you a sense of like why the relationship is not so close, or why there's some anxiety or a lack of, you're thinking, oh, this person has a mother and a father and cousins, but maybe they didn't even grow up with all these people, right? So really understanding like what is the support system of this individual, and what are any potential trauma history. Sexual abuse is obviously a really important thing to know about people's whole physical reproductive body. Some part of their body that was engaged, probably related to sexual assault, is going to be engaged and maybe over engaged in the prenatals, in the childbirth experience, in breastfeeding and caring for a baby over time. And so getting to know those things early, very important, because very quickly they can play a role in what happens, even people avoiding going to doctor's appointments. Maybe the doctor is inconsiderate. They keep touching them too much. They, are too rough with them, and they don't want to go to visits. And everybody's thinking this is about them being lackadaisical in their care. And really they feel re-traumatized, or they're feeling triggered in some way. And the doula or the midwife or even the provider, if they're asking these questions, can be more sensitive to that. So really it takes a whole picture to understand a person, especially during this period of time in their lives. And the more tools that you have to do that, the better. The other thing that I would say is we're talking about a lot of like deficient things, right? Like a lot of things that could be wrong, that could be problematic. But the resiliency side of things is also really important to understand. So there's a similar screening called, I call it the PACEs screening, but protective domains for the ACEs. And it looks at attachment and nurturing. So maybe you had a parent that was formerly incarcerated, or it was incarcerated or is still incarcerated, but you had a really active grandparent who raised you, and you had neighbors and you felt loved and cared for. So there's a lot of questions about, when you were young, did people play with you and you heard stories that you were happy as a child? Do you remember feeling safe and secure as a child? Do you remember particular providers or caregivers who loved you and told you that they loved you? So it's really getting to, even if you had difficulty, which happens in life, we are resilient beings. And so if I know the things that helped you go through difficult times in the past, then I might be able to pull on some of those things if you get into some trouble or you just feel like you're struggling at this time.
Mm. There's so much juicy stuff in there that I want to respond to, but I just so appreciate that you kind of provide the full range of opportunity for exploration and of any life experience that we have. People who are introducing or trying, even just trying to introduce a baby into their family ecosystem, all of these things come up again.
Oh yeah.
Whether you ask them or not,
Right.
there are elements of this that are emerging and coming up for them. So why not create a space for them to openly kind of reflect on that?
Yeah.
And because they might have already been thinking about, oh, how was I parented? And what kind of environment was I birthed into?
Right.
And what kind of environment do I want to create for my own baby?
Yeah.
And whether they even know it, these things are
Oh yeah.
surfacing. And so these are opportunities for you to open that. What I also appreciated about what you said, though, is that, again, if you're not a therapist and you're not there to do therapy,
Right.
literally, it's not your job, or you don't have to feel pressure to open Pandora's box. That's
Right.
not the intention, right? Is
Right.
not to have them tell their whole trauma story.
Absolutely.
There
Yeah.
are times where people will want to do that
Yeah.
when you have the kind of presence that makes them feel sometimes safe and heard for the first time in their whole life.
Right.
Often I
They're
have
like,
to
oh, you're
remind people,
listening. I can tell
I
you
know.
everything now. Yeah.
Exactly. Then they, want to start,
Yeah.
unloading all of the things. So you have to kind of think about that, which we'll
Yeah.
get to eventually.
Yeah.
Think about how you want to create parameters around that. But these are tools that you can use to kind of explore what were this person's life experiences and how do they shape how they're going
Yeah.
to be navigating this. I know that in my experience in working with other healthcare professionals, training healthcare professionals around this, for many of them, it's helpful to have a plan in place before they start asking these questions that then kind of makes them feel a little more comfortable and easeful in even going into navigating and exploring what people's experiences were. And I wanted to name that on the screening tools we were mentioning earlier, the PHQ and the Edinburgh Postnatal Depression Scale in particular, which, by the way, we will have linked in the show notes for you to review if you're curious at taking a closer look. But number 9 on the PHQ-9 and number 10 on the EPDS both ask legitimate, straightforward questions about suicide.
Right.
And so, that is one area that people feel
Yeah.
sometimes the most
Yeah. They're like,
discomfort
do I
about.
use that? I'd really rather not use this
I'd rather
because
not
I don't
ask
want to
at
get
all.
to number 10.
Yeah, exactly. And I'd rather not ask at all. Or even the way that they ask the question is kind of trying to solicit a particular response because they
Right.
don't really feel comfortable if someone does say, yeah, I've been having some really tough feelings and it's been that I've felt like I've thought about harming myself. And
Right.
so I just wanted to name that in those circumstances, it's helpful really for all of this that we're talking about, but it's really helpful to already know, okay, what would I do if this came
Yeah.
up? Who is available to me? Do I have a Dr. Saida on speed dial that
Right.
I can call
Right.
if someone is sitting in front of me expressing suicidal thoughts? What are the crisis response resources
Right.
that are in the area? Where's the nearest ER? How do I what kind of relationship do I have with the other family members so that I
Right.
can make sure perhaps there's
That's
someone
key.
that can be present for the baby if this person needs to go get support.
Yeah.
Thinking about these things in advance
You have
rather
to.
than when you're sitting in front
Yeah.
of the person and it's happening can really, I think, bring a sense of ease with starting to introduce these screening tools into the practice and, make that experience much more easeful across the board.
And this is why I think we wanted to start with this because if people are thinking about screening, but they don't have like a plan for the plan, then they'll get into a situation like right now, people are being told do screenings. Lots of providers are suddenly required to do screening because of policy that's been passed, which is great. We want people who are pregnant and postpartum to get screened. But if you're not trained, not just in like how to do the screening, but like what you should be thinking about when you're doing screening, like what if the worst outcome of the screening is here? Do I have a plan for it? Do I have somebody to call? Am I going to give them a warm handoff? Can I even let someone? So I've had people call me in real time, like a provider who they're like, this person says they're suicidal. I have another client in 15 minutes. Like I didn't, I don't have a plan for that. So people who are new to doing screenings, thinking about now they're in a situation where they don't have a plan. And then they're calling somebody they happen to know, like, well, could you help me get a plan? And then it's like, we should have had a plan way earlier than this. Mm-hmm. So I do want people thinking as they're thinking about this topic, like get some notes down for yourself. Where do you live? Like, who do you know that is a mental health professional? Mm-hmm. Do you know the crisis line to call? For whatever reason, and not happenstance, just because of the field I'm in, and I've been in a lot of suicide crisis management work, I always have the number wherever I live to like the local mental health like team that will go out. So in most cities, there's a team of people that are on call 24 hours a day. They're not 911. They're a special number that they will come to your house or come to the Starbucks or come to wherever you are and do an assessment to determine if you're suicidal. And if you are, they bring you to the hospital. So when I used to work in a psychiatric hospital, sometimes the MAT team would bring folks that they found, in the community to us. And that's when I learned about like, well, who are you MAT team? Like, I know we're at the psych hospital doing assessments. People bring folks to the door of the psych hospital, but that is a thought. Like, what if your cousin says they want to kill themselves and you are just home with them? Or if you're go ahead.
I want to say too, do that instead of calling the police.
Yeah, right. And that's what we want people to do is to call the MAT team. And I'm saying MAT team, it could be called something different
in every city. Exactly. But we're doing that instead of calling 911.
Because they know how to respond.
Yes.
You call 911 and I'm like wanting to stay on the phone with 911 to make sure that they understand this is somebody who has a baby or, is pregnant. They have a secure support system.
Yeah.
There's not a dangerous emergency that you're walking into, but then also like family members, stay with them. You can't leave them. Strategizing with that. But going back to the provider. So, right, it's like, no, you actually ideally need to stay with them. Like you don't need to stand over them and hover, but if there's a room where they can wait, where somebody can be with them, another staff member. And then, yes, you need to come up with a plan to get them in the hands of someone who can actually do an assessment, right? So what you're doing is like a screening, right? But a real assessment is somebody who's trained to do in California, a 5150 to really decide if this person needs to be, taken into more intensive care. And then, once they get into our arms, I'm saying like those who work in that acute psychiatric space, we know what to do. But between that group of people and whoever is with them when they first say they're having challenges, that's the difficulty is most people don't feel like they know that. And I do think that some of that is like an opportunity for public health to make those numbers more available to people. Like people shouldn't have to call me to know who the team is that they can call if somebody is having suicidal thoughts in their home, because I'm not available for everyone. That's not actually even my role in the work that I do today, right? Like they're just calling because they know I'm a psychologist. Yeah.
And that you know what to do. And also, I think in some spaces, those numbers, they can sometimes take a while to respond.
Right. 4 hours is some of the standard ones in our area.
And that, like,
so
who
what
has
are you doing
time
for 4
to
hours?
say, what are you doing in that time? Exactly.
And they may get up and leave. They may say, I'm not staying here, right? And then do you physically detain them? I mean, it's gotten intense. I mean, I'm sure you've had calls as well that you've tried to manage. It's not fun. And then in those cases where the person is not willing to sit tight, then you might need to call the police, right? If you really feel like there is an imminent danger.
Right.
But, we're maybe getting a little bit too much into the weeds.
Well, but I think this is a good transition to something else that we wanted to lay the foundation, because this is the whole purpose of this first episode, is to just what is the landscape? What are we really talking about here? And the other thing that I want to say about this is that oftentimes those crisis response teams, they're not trained either in perinatal mental health.
Yeah, they're
And
not.
so
Yeah.
like we have a role in advocacy, because I heard that, if you are on the phone with 911, I'm going to stay on the phone and let them know until they get there and do their assessment that this is what they're dealing with, and don't respond in this
Right.
way.
Don't
And
come with the guns
this
blazing.
is the real
Yeah.
risk here. And so I want to just kind of lay that out for a moment. Like, for perinatal mental health, what are we really talking about here?
Yeah.
We've named depression, we've named anxiety, and that often depression and anxiety can go hand in hand. We're not always talking about people who have a full-blown mental health condition.
Right.
There are people who may just have such debilitating anxiety that it makes them suicidal.
Right.
We are also talking about situations where folks might be experiencing conditions that are often misinterpreted and assessed, I suppose, for their level of risk. So one in particular that comes up often is obsessive compulsive disorder, perinatal OCD, which oftentimes parents, moms who are experiencing perinatal OCD, it can happen during pregnancy. Most often it's in postpartum. It is occurring because that kind of primal drive to protect your baby goes a little bit overdrive. And folks start having really scary, intrusive thoughts and sometimes even images of bad things happening to their baby, sometimes death, like death related, safety related. And so what happens is they have these terrifying images. And then the compulsion, so that's the intrusive thought. The compulsion that happens are these efforts to protect the baby, to prevent harm from coming to the baby. But often the images that they're having are so terrifying, they're also terrifying to the provider and to the person who's doing the assessment. And so they might often respond in a way that institutionalizes mom and separates mom from baby, that, sometimes might even run a risk of child protective services, because oftentimes these folks don't know what they're looking at.
Right.
That is not the same as like a postpartum psychosis,
Right.
in which case that is a real emergency.
Right.
There is imminent risk to the infant. It's not the same thing as OCD. And the way that I teach people to kind of differentiate is, how does that mom, like, what is her awareness of what's happening? How does she feel about what's happening? With OCD, oftentimes there's this debilitating shame and guilt for ever having these intrusive thoughts that they can't control, and they just keep coming up.
Right.
And like, what are the behaviors they're doing to actually protect their baby? And they're actually more likely to be suicidal because they feel so bad. Yes, it's internalized. And they're like, maybe if I'm having these thoughts, it makes it possible that I could harm my baby. So maybe the baby is better off without me. Right. Whereas in the case of psychosis, this person has had a complete break from reality. They are operating from a delusional space. They are not present. They sometimes are hearing voices, hallucinations. Sometimes it can feel real off. Like it just, you can tell something's off. But you can't quite put your finger on what it is.
And I want to say, I've heard birth workers say to me, like, I don't know, but I just feel like I can't leave them. And I'm like, oh, no. This is when you feel like you can't leave somebody, and not just like, I'm not sure if she's going to get enough sleep tonight. And so maybe, but like, I'm not, it's like, what are you not sure about? You are thinking something. You can say it. Like, you can tell me, birth worker, that you feel like something's off here, like irrational, or like, but if you ever feel like anxious about leaving a person, and like you start gathering their support system, not just because they're a new mother, right? There's a difference between like this and something that you almost can't name because you don't necessarily have the background, but you feel it.
Yes.
It definitely is like, respond to that. Yes. Don't just assume that you're being over exaggerating, because you're the most neutral person in the setting. You're not in the family. You're
not mandated reporter, right?
That's true. Doulas in particular are not mandated reporters. Right.
Yeah. So you have a unique position to be able to like, okay, let me be responsive to this and put some more protective measures in place so that I can even hopefully improve the trajectory of this. And if something were to go down, there are kind of these supports and buffers around this situation.
Yeah, like you want to get the right person in.
Yes.
If you feel like that, it's time to tag in mental health. It's time to say to family, this is not normal. Yeah. This is out of the scope of like normal range. I need you to call her. Even the OB is the person that typically people would end up calling. Like, there's something going on and you're the closest thing that I know to somebody to respond to. And OBs are meant to be trained, although we are part of a lot of those trainings with even the medical providers to get more comfortable with perinatal mental health. But they do have it within their scope to make the appropriate referrals. And they're supposed to have those referrals available. And of course, insurance companies, particularly if they're with a managed care plan, are also supposed to be able to, there's a number and you're supposed to say, hey, I think we have a mental health issue. Who is a provider that you could go to? Like, there are people that could be available, and those people need to be tapped in and tagged in.
Mm.
If you just leave it and assume that the family, not that you, like, you can't, and this is the tricky thing for the like, this person is not your clinical client. They're not your patient. You're a support system for them. You're the lactation consultant coming in and noticing that something's a little off. I mean, she's got the breastfeeding thing going, but she's saying some things, or there's something. You got to tag on the people that are obligated and responsible for that and trained in that, and so it is why we're having this conversation, so that people can even just start getting used to thinking about, do I even know this? I might need more training. Like, a person listening right now might be thinking, this feels very like, now I don't feel like I know what I would do. You just need to get more training.
We got you.
Yeah.
We will link,
we will link
some trainings if you want to go deeper.
Yeah, you can only do but so much in a conversation.
Right.
But these are things that you should be aware of.
Yeah. And also I want to name, like, we didn't learn all of this in a 1-hour training.
No.
We picked up on all of this knowledge over the years of working with families and kind of starting to familiarize ourselves with the system and how the system works and how family systems work. And when there is one person, sometimes more than one, right? Because also dads can experience postpartum depression. And if the birthing person, mom, is experiencing depression, his risk goes up. Their mental health has a direct correlation to each other. And so we're not just talking about the person who the baby came out of their body. We're talking about everybody involved. But, the more that we learn, I think, over the years, and even in our own experiences, I know for me, in my postpartum journey, I struggled with my own mental health, and I was already doing this work.
Right.
And so it was really just shocking to me. And that I thought that I had done all the preparations, but still nobody asked me about my mental health. And I did not feel comfortable telling people how I was really feeling, because I had so much shame, and like, it's so taboo for you to feel like, I'm not fully enjoying every moment of this.
Your life.
Or like, I can't, exactly. And oftentimes people just can't even wrap their minds around articulating the complexity of the emotional journey, the psychological journey that's at play.
Yeah.
So
I would say too, I think for me, in my experiences, when I had my girls, particularly, I mean, I had pretty strong anxiety at different times in both pregnancies, but people are looking for depression and they're not looking for anxiety.
Right.
So people are, how are you feeling? And, do you hopeless? Or no, I feel great. I mean, like, I don't feel hopeless about anything. I know this is going to, I felt really strong about what my birth experience would be. I was really focused on wanting a natural birth, and I wanted to have, a certain kind of experience. And so I felt activated there, but I was highly anxious. Like, I got to a point where I was like praying for the sun to rise at night.
Yes.
Because I was like, well, maybe if I don't pray enough, the sun's not going to rise and then the world's going to end. And it was it was completely irrational, like beyond rational.
But you were still able to function.
I was highly able to function. I was in grad school. I was still working. I was doing all the things.
This is many of the people we're talking about.
Absolutely. And when I was on the maternal suicide review committee in California, a lot of the people who had suicides were the high functional, highly educated, working women, positions of leadership, and this kind of like, they're highly functional. Their houses were neat and clean. I'll never forget, there was a case, and it was one where like the coroner's report or somebody's report was about how neat and clean the house was. And I thought that was so odd. But as a psychologist, I was like, and as somebody who was like a little bit OCD personality and anxiety, that kind of world is more where my pendulum swing. I was like, oh yeah, that was somebody who was trying really hard to keep it together. And the only thing they could do was clean the house, because whatever was, it's like, I can control this and I can do that. And so I can make all that, but they could not deal with whatever was going on. And ultimately, they lost their life. And so it's really important for people not just be looking for depression, particularly for women of color who are like very normalized to high functioning, high intensity. It's not going to look like, a crying, desperate, needy, like people are imagining, it's very clear what that would be. Oh, I will know you need something. And it's like, this person's going to say, no, I'm doing fine. It's like, most experienced birth workers, even if they're not mental health people, will say that quick response after you just had a baby already makes me question it. Like when it's like, I feel like it's like a grandmother, auntie's perspective. Like,
Mhm.
you sound like you're,
How are you really
yeah, like
doing?
that was too quick of a response. You're just
Yeah.
amazing. You're not really, I know you're not
Right.
sleeping. I know you're still
I know you
bleeding.
in a diaper.
Yeah, exactly. Like, what are we
you
talking
sure?
about? Yeah, this isn't amazing. Real mothers know it's not amazing at this point. You're going through it, and you might be grateful, but you are still. Where could you get support, right? And if they're like resistant to that, then it's almost a sign of like you're doing over good, and that
Yeah.
means you're holding, and you should be fully supported.
Yeah.
It's almost like the ancient tradition is like, make her sit down for 40 days,
Right.
feed her whether she wants to eat or not. My Chinese friends are always complaining about like the overfeeding that they get when they have a baby, because they're like, I don't even feel like I need all this. But the ancients know it doesn't make a difference. We know to get mothers through, we have to make sure that they get over supported so that they never have to do that like holding thing that takes you off the edge. Yeah.
Something that you said, I want to also add another expression that this could look like. You were saying there's the quick response, I'm fine. And that's like the high functioning version. But there's also another kind of I'm fine where like I'm numb and I'm completely disconnected from this experience. And
Yeah.
I don't have anything else to say other than I'm fine.
Right.
And I noticed we also haven't really talked a lot about trauma in this whole scope.
Sure.
We've talked a lot about anxiety disorders. We've talked about psychosis. We've talked about these things. But how might folks recognize trauma, which is another whole
it's very
series
nuanced.
and nuanced.
Yeah.
But, I want to just name that when we're saying perinatal mental health, we're also talking about trauma. And it's not just someone who had, a traumatic experience in the past. They could be experiencing something that is being integrated as traumatic during pregnancy and postpartum. They can have a delayed response in those first few days, weeks, months. They may not really be processing or connecting to what happened, or that experience was traumatic. And so I wonder if we can also kind of differentiate there that nuance between the I'm fines.
Yeah. So, I mean, I think, with trauma, let's just like specify a birth trauma, right?
Yeah.
So you had an unexpected experience in your childbirth. I'll give an example of something that a mom was telling me recently. She was expecting to be able to get an epidural after having had a C-section the first time. And so there was like this strong resistance to having an intense physical experience because it wasn't what she had before for her first baby. And she was told she could have an epidural. And so that was the plan. And then she had a very fast moving labor and ended up having to push with no epidural and fought it the entire time. And yeah, you could just feel the like, oh, dang, you just know like that just, we can imagine that. Like if you've given birth and if you've watched someone give birth before, there is over time, over the hours of getting to the moment when you're going to push and the baby's going to come out, you get some time to get your mind wrapped around the experience. Like, even if it's the first time, it's like, you don't know what's coming in the next moment, but to be quickly forced into something physical like that and to have no control because your body takes over when it's time to push. Like there is no stop this. Nobody can stop it. Your partner can't stop it. The doctor can't stop it. You can't stop it. No. So if you don't release, I mean, the doula in me is like, I wish I was there because I'd been like, we don't got time for all that. Right now, we're just going to be with the ancestors and you're just going to breathe and we're going to get, line up with releasing this baby. Don't fight this because you're fighting the wind. Like at this point, what are you going to do? Like you're fighting a tsunami. And so, but the reality was that experience was really traumatic. And so when people were asking, well, how are you feeling? It's like, she just had a healthy baby. Everybody's so happy. Oh, and you didn't even have a C-section. Like all of these assumptions that this was a beautiful experience. Oh, it was so fast. You had a baby in a couple hours.
Yeah.
Right. Like what people think it would be. And it's like,
that they should be feeling.
I don't know. Like if you've ever had trauma, it takes a while for your brain to catch up with even what happened because it was so unexpected. And then to add the physical pain to it, to add hormonal changes to it, to add, then you got a baby, your new baby. Yay. And you're supposed to be happy. And then if I saw you 3 days later and we're talking about this, or a week later, you've been breastfeeding that baby every 2 hours, like you still have to be on. There's no time for mothers to go off and process, right?
Right.
So it's very like unique, the birth experience, because most people, no matter what kind of trauma they have, they can be removed from the situation and pause and take it in again. There's no pausing. There's no pausing. And so if you really can't handle it psychologically, if something is that traumatic and also you have your coping is so compromised because of other past things, that could push you into a psychotic state or to some kind of like really strong emotional state that means you need more support than even you managing it yourself.
Right.
But just how do you notice that something untoward even happened when you're meeting with someone? I think noting that kind of like blank stare, the like missing pieces of a story. I often notice that like,
Yes.
like it can be nice. A lot of times as a birth worker, I'll like process with people. Let's walk through it again. If I wasn't there, even if I was there, because it's always interesting. I might have been there, but you might have had a different interpretation of your experience than I interpret it, right? So somebody going through the birth story with you, listening for anything that makes you feel in your gut. And we're going to talk about this more in a future episode. I feel like something was missing there. I feel like I thought there was going to be more emotion there. I feel like there was a lack of clarity about it or
especially
an avoidance.
compared to their baseline, right?
Yes.
Like how you knew them.
Right. Like how they talked about things before.
How you experienced them before compared to now. Like,
yeah,
let me get curious about this.
Yeah.
Yeah.
So there's a lot of things, as you can see, that there are to think about when you're assessing, screening, understanding a person, how to support them. We covered, as we wrap up this first part, you want to think about general wellness, like general mental wellness. How are they coping? How are they feeling? What's their baseline? You can get a sense of that through the screening tools. You can get a deeper dive looking at past history if you think about the first childhood experiences. Don't forget about protective factors, things that you notice yourself look like. It helps them be really strong and cope better. And also the formal assessments that you can do. You want to think about how you feel. And we're going to talk about that more in later episodes about like how you feel as a person listening to them. And you want to note this over time. Like, don't just do this once at the beginning.
Right.
Like, take a note, remember how it felt with them, how they describe their feelings. And, some way, I always feel like 3 months is a nice cadence. Like the trimesters are nice cadences to like check in, like we're in a new stage. What is it feeling like now? I don't think you can over screen when you use it in a relational way.
Right.
Yeah.
Yes.
Yeah.
I just have so enjoyed this conversation and helping people understand what we're really looking at and why it is important to be asking these questions. And yeah, it's definitely important to be looking at, physically, how is the pregnancy moving along? But we also know that in a lot of spaces, we're focusing only on the health of the pregnancy. And then once the baby's born, the health of the baby. But then what about the person who's taking care of the baby and how well are they coping and managing so that they can really fully be present for that experience? Because that's that's what I've learned. If anything, I've learned that most parents, most moms, they want to be their best self for their baby. They will give the very last of their resources to their baby. Absolutely. And then what's left for them. And so we can help them bring them as part of that equation. Like we're not turning any attention or resources or care away from the baby. We are incorporating you in the care that we're providing to the whole family unit and making sure that this whole family unit has what they need to thrive and not just white knuckle it through this experience and get to the other side and say, I survived. It's like, you don't have to do that.
No,
that's necessary.
And that's not what building a family is about.
No.
Like one person suffering through
so
that this next one, they don't, because the thing, especially if you're feeding from your body or if you're the one that's waking up and feeding them, even if it's with a bottle, you're the one that has to respond to the cue. You need to be like full and rested. And we know that it's never going to be 100%. I mean, that's just not real, but it can be enough. It can be enough and you can feel supported and you can feel like you have what you need to give and because somebody's giving to you. And let's be the village for that.
Yeah, and I also just the takeaway for me is this spectrum. It's like there's a spectrum of experiences. There's also a spectrum of responses. Like in the case of that person that gave birth without the epidural and things, and there were people kind of projecting on her that experience, how she should be feeling. For pretty much everything in this, it is unique.
Yeah.
Each person is going to respond differently to different things, and so we just get skilled at meeting people where they are,
Right.
trying to see, okay, for you, what has this
Yeah.
experience been like?
Yeah.
And for you, what will be supportive? These are some things that might have worked for other people in the past or may have worked for me in the past, but let's find what works for you.
Yeah.
And so that's really what we're
Yep,
what we're
that's what we're
talking
doing.
about.
Yeah, that's what we're talking
the
about.
cherry on top is
Yeah.
what how do we know that there are tools out there to support you, but really making this a person-centered, patient-centered, client-centered space
Yeah.
that you are already doing this really deep connection, intimate relationship building work. How do we just incorporate this into what you're already doing?
Yeah. Great. Good way to end.
Awesome. Thank you.
Yeah,
Well,
same.
I look forward to continuing this conversation, and we will pick up next time on a little more specifics on, okay, what does this really look like in practice?
Yeah. Awesome.
Thank you.
Thank you.
We want to thank our funding partners for supporting our work and you for tuning in today. If you like what you've heard and you want to hear more, drop us a line in the comments so we can connect. In the meantime, take good care and be well.